former Attorney General Ed Meese said that an expert is somebody who comes from more than 50 miles away, has no responsibility for implementing the advice that he gives, and shows slides. I'm only coming from 4 miles away, but 2 out of 3 ain't bad. I do want to just make one observation about a connection that I have to Regions. My wife's grandmother worked at St. Paul Ramsey and formerly, I guess, Anchor as a labor and delivery nurse for 20 years. So that's my connection. So let me give you a quick orientation to where we're going to go. A lot of people, when they start on a presentation with medical futility, start with this slide, which is a wife standing over the physician who's kneeling with a stethoscope before a tombstone, and he says, "I'm afraid there's very little I can do," right? And the reason that they start with this slide is because the problem or the issue of medical futility is often framed as the problem of surrogate-driven over-treatment, right? The clinicians think that the medically and ethically appropriate course of action is comfort measures only, but the surrogate wants to continue life-sustaining medical treatment. So there's just 2 quick distinguishing features, which you're probably already surely aware of medical futility disputes, is that they usually concern ICU treatment, and secondly, the patients that we're talking about usually lack decision-making capacity, so treatment decisions are being made by a surrogate. This is a big problem. In a study published just a few weeks ago between UCLA and RAND, they did a study of 1,100 patients, and the survey of the physicians treating those patients, they reported that they had provided futile treatment to those patients 11% of the time, and an additionally probably futile treatment in another 8% of the time. So in other words, about 20% of the treatment that was being provided was either futile or probably futile in the perception of the treating clinicians. And that's actually consistent with prior published studies, this one from JAMA in 2011, where again about 20% of ICU treatment was perceived by the treating clinicians to be disproportionate, I think was the term used in that study. I do want to take 30 seconds, though, to step back, provide a little piece of context, and that's that the far, far bigger problem than surrogate-driven overtreatment is clinician-driven overtreatment. This is a 2011 Lancet study that found that 30% Medicare beneficiaries received surgery in the last year of life, 20% in the last month of life, and 10% in the last week of life. But of course, the gold standard exhibit in terms of clinician-driven overtreatment is, of course, the Dartmouth Atlas, which is the most robust churning of Medicare claims data that there is. And the color variations, that's enormous variability in intensity of treatment, not due to severity of illness, not due to patient preference differences, but solely due to clinician preferences in how they treat those patients. Minnesota actually, of course, does really well in the Dartmouth Atlas study, right? So compared to New Jersey, for example, where way more people spend way more days in the ICU in the last month of life, see 10 or more specialists in the last month of life, way less use of hospice, right? So Minnesota does pretty well, but at least at the national level, clinician-driven overtreatment, really big problem. All right, just had to say, for context, not going to talk about that. Here's my roadmap. And I want to proceed in basically 5 stages. I want to talk about the causes of medical futility disputes, how they can be prevented. When there is a dispute, can't be prevented, usually consensus can be reached. But then to turn to talk about those disputes in which consensus can't be reached, the intractable futility conflicts. And then I want to describe a new multi-society policy that's been drafted and it's currently out for peer review. All right, so the causes of medical futility disputes. This is a survey that was published in the Archives of Surgery in 2008, and they asked about 1,000 members of the public and 1,000 medical professionals this question. If doctors believe there's no hope of recovery, which would you prefer? Well, 21% of the public said even if there's no hope of recovery, all efforts should continue indefinitely, but only 3% of healthcare professionals agree with that. So the problem really comes from this gap between the amount of the public that would want to continue in these circumstances and the number of healthcare professionals that would agree with that. So there's this gap between what surrogates are demanding and providers are resisting those demands. So I just want to look at both sides of that equation, because that's what produces the conflict. On the one side, why do surrogates demand life-sustaining treatment that's not recommended by their treating clinicians? Well, one reason is cognitive, right? They just don't understand the prognosis or the diagnosis of the patient. And to be fair to the surrogates, a lot of that confusion or misunderstanding is iatrogenic, meaning it's caused by inadequate communication from the clinicians, or they're getting uncoordinated and even conflicting information from a number of different specialists. And it's obviously they're under a lot of undue pressure, and it's hard for them to process this information in any case. Mistrust is a big reason, right? And there's several different types of mistrust. One is prognostic mistrust. They know that it's hard to prognosticate, and they know there's limits to that. And with greater access to healthcare information, surrogates feel more empowered to question their physicians. And there's other types of mistrust, racial mistrust, right? Especially among Hispanic and African Americans, right? They feel, well, the reason you're making this recommendation for comfort measures only, it's not because of the prognosis, it's because of our race. Financial mistrust, right? They feel the reason you're making this recommendation is to save the hospital money or to save Medicare money, right? Obamacare, seniors check in, but they don't check out. There's a big fear, right, still, of death panels. There's emotional barriers, right? There's a lot of complex family dynamics. There's relationships, issues of guilt, feelings of guilt given the relationship between the surrogate and the patient, or feelings of loyalty between the surrogate and the patient. They don't feel they can let go. And there's lots of psychological barriers, right? The surrogate is experiencing significant anxiety and stress and depression. And they feel, look, if we can put a man on the moon, then surely we can save grandma, right? The world mortality rate remains 100%. But people really feel like, gosh, with all these billions of dollars going to NIH funding, surely, we can make a dent in that. They feel that, like King Canute, right? We can hold back the waves, right? Never give in, never give in, never, 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 never. And this optimism is fueled by books like this one by Sanjay Gupta called Cheating Death, which recounts all these stories of medical miracles, and by new studies like Adrian Owen's research, which shows that we can communicate with long-time vegetative patients by using fMRI, measuring the brain reactions to verbal cues using fMRI. And apart from this optimism, some surrogates are just in denial, right? They're just simply in denial. The grass is always greener on the other side, and they just want to assert their autonomy. But the biggest reason for surrogate continued demands for non-recommended treatment is religion, right? Surrogates feel that it's not their call, it's not their decision, right? It's not for me to decide when it's time to stop, it's up to Jesus. And there's a very big belief in miracles. Just going back to this Archives of Surgery survey, another question was, if the doctors treating your family member said futility had been reached, would you believe that divine intervention by God could save your family member? Nearly 60% of the public said yes. And religiously motivated demands for treatment are among, and I'm going to come back to this, are among the most intractable. All these reasons, whether they're cognitive, psychological, religiously motivated demands for treatment, are all sort of easy for surrogates to act on. Sorry about that. Got snagged by the drawer. Okay. Because the costs are externalized, right? And what I mean is they're not paying for it. The financial costs are externalized to Medicare. The costs in terms of caring for these patients are borne by the nursing staff. The family's not there every day, 24/7, right? So it's easy to act on any of these motivating factors. And the numbers are growing, right? A few days ago, the Pew Research Center published a study called Views on End-of-Life Medical Treatments. And you can see right in the subtitle, which is called Growing Minority of Americans Say Doctors Should Do Everything Possible to Keep Patients Alive. And one of the main outcomes of the study that's already been reported widely in the media is that when they asked the same question in 1990, doctors and, do you agree with this statement? Doctors and nurses should do everything possible to save the life of a patient in all circumstances. In 1990, only 15% of Americans agreed with that statement. This year, 31%, right? It more than doubled. That's 1 in 3, right? Basically, 1 in 3 Americans believe you should do everything possible in all circumstances. It's worth noting that if you break that down and you look at just some subpopulations like Hispanic Catholics, it's way, way higher. It's 66% of Hispanic Catholics agree with that. That's 2 out of 3, and half of Black Protestants, right? So it's really high numbers here. And this is not, in the Pew study is not some sort of outlier, right? It's basically consistent with a lot of other published studies that show the same thing. At the national level, this is from the National Journal, 20%. It's a California-specific study, 27%. And even international studies, this is from Ireland, again, 20-some%, right? So this is pretty consistent. We have between 20 and 30% of people think it should continue at all costs. Okay, so that's the surrogate side of the equation. Let me just turn now to the other side. Why do clinicians resist these requests or demands? I think the single biggest reason may be that they want to avoid patient suffering, right? They feel they don't want to be complicit in what they basically feel is torture, to continue to provide care that the burdens are disproportionate to any benefit, if there is any benefit at all. And some of the quotes here colorfully illustrate this. This is the Massachusetts General Hospital, not Auschwitz. In another case, I don't see much difference between what we're doing here and the atrocities in Bosnia. Another reason to resist is that medical futility is the single biggest cause of moral distress, especially among the nursing staff. And this has been well measured, a ton of studies now. And it's a big problem. And it's not just for the nurses, but it also causes absenteeism, retention issues, and it negatively impacts the quality of care provided to other patients, right? So there are third parties negatively affected here as well. Clinicians want to stand up for the integrity of the medical profession. They're not just vending machines to do whatever the surrogates ask for. Who's this? Like Pinocchio, right? They don't want to be puppets of the patient. They don't want to be caught in this Pinocchio syndrome, either being puppets of the surrogates or being dishonest toward the integrity of the profession. Clinicians want to be good stewards of healthcare resources, especially hard resources like ICU beds, when there's a patient who has a high probability capacity to benefit from that ICU bed but might be denied because it's filled. And even of soft resources like healthcare dollars. But and I'm going to come back to this one, a very big reason that clinicians resist surrogate demands for continued life-sustaining treatment is because they distrust the surrogate. They distrust that what the surrogate is asking for is what the patient really would have wanted for herself. Or at least what's being asked for is in the patient's best interest. All right, so that's some of the reasons why we have conflicts, because we have motivating factors to continue this treatment, motivating factors to resist the treatment. Ideally, we can prevent these disputes, right, before they arise. Prevention is always better than cure. So we can catch a lot of them right at the top of the funnel before they go down. We know, and this is consistent with the Pew study, right? We know that 71% of Americans believe it's more important to enhance the quality of life for seriously ill patients, even if it means a shorter life. Same thing in the Archives of Surgery study. We know that 70% of people would prefer to die at home, but in fact only 20% actually do, right? People are not getting what they want. We have some tools that are helping to close this gap between preferences and treatment. One is POLST, right? POLST has proven as a tool to help make sure that the treatment patients want is the treatment that patients get. And hopefully, in order to really help expand the use of POLST, Representative Blumenauer, among others, may get sometime in the next 5 years some federal legislation that would up the Medicare coverage for doing conversations with patients. At the state level, lots of states are mandating broader end-of-life disclosures so people know what their options and alternatives are at the end of life. A lot more states are mandating more CME, continuing medical education, on issues like palliative care and end-of-life treatment. Even at the professional association level, there's a big push to expand informed consent to make sure that patients are aware of the limited effectiveness, side effects, and options. A lot of professional associations are participating in the Choosing Wisely initiative, and there's a lot of development now of patient decision aids, videos, interactive web programs to help make sure informed consent, including about end-of-life, works more effectively than it does now. In Minnesota, we have a pretty good initiative to help expand advanced care planning, and there's a lot more, probably more than ever now. There's this new show on Showtime, among others, more public discussion about end-of-life issues. It has more visibility just in the media and in society probably than ever before. Still, let me just go back to the Pew study for a second. Still, unfortunately, rates of advanced care planning remain sort of mediocre. Even among the elderly, it's barely over half. So we're still going to have, we can do more in terms of prevention, but we're still going to have some conflicts. The good news is most of those conflicts can be resolved informally, right? Consensus can be reached, so I'm now moving down the funnel a little bit. Overwhelmingly, in the whole universe of medical futility disputes, consensus can be reached almost all the time. There's only this tiny little subset of medical futility disputes that remain intractable. There's Kaiser Permanente published a study a few weeks ago. They had 92 futility disputes, and then after they had family meetings. After 1, 2, 3, 4 family meetings, they only had 5 futility disputes, right? So basically, 5 out of 9, about 5% remained intractable. All the rest were able to be resolved, and that's consistent with all the older published studies. Back in '98, Prendergast had published a study when you make a recommendation for comfort measures only, 57% of surrogates agree immediately, 90% agree within 5 days, and then after a few more meetings, the consensus rate between the clinicians and the surrogates goes up to 96%. A study by Guros a little bit later showed the same thing. Find and Mayo, the same thing. And then in a really big study in Texas of 3,000 futility disputes, only 60 remained intractable. So consensus was reached in all but 60 out of 3,000, 5%, right? So we have this 95% agreement rate. And this is why I think the AMA Code of Medical Ethics, their model futility policy, devotes 4 of its 7 steps to things like deliberation, negotiation, joint decision-making, right? Because these things, they work, right? They work. So that's why 4 out of 7 of the steps are focused on that. And I think even your own futility policy focuses a lot on mediation and better communication because that works. So 95%. So what I'm going to do now is there's this 5% of conflicts that can't be resolved, right? We can't reach consensus between the clinicians and the surrogates. These are the so-called intractable futility conflicts. And since you invited a lawyer to come talk to you, this is basically where I'm going to focus the rest of the talk.